The mechanism behind a repetitive type of drop, like on this table, or Raphael table. Because there is an auto-cocking mechanism, the contact is kept between drops, and there is no need to let the contact go to reload. Successive automatic drops have the advantage to decrease the resistance of each one of those drops, because basically you go against the viscosity, natural viscosity of the ligament. And when you replace a single drop with repetitive drop, you need much less intensity, and it's quite more effective if the segment is very tight. So on severe fixation, it's what we will use. So this is going to be a single drop and a multiple type of repetitive drop. Both sides, both type of drop are a bit different, but the repetitive drop allows you to fight against the ligamental viscosity, and you don't need as much pressure as with a single drop. You still have to be careful with acute patients. The sacroiliac drop and its facilitation with the arc of tension. The effectiveness of a drop depends mainly on 4 things. The drop should be brisk and responding consistently to the same pressure. If you put 10 pounds, it shouldn't drop at 15 and then at 4. So it should drop at 10. Any part of the table section should be responding to the same level of pressure, because when you treat a patient, you move him around. So that's something that you have to check up with your table. And finally, the height of the table needs to be adapted to the height of the doctor, especially for a cervical drop, because there is a question of safety here, but also because you don't want to drop a patient when the table is at that height. And finally, the consistency of the foam is quite important. It has to be firm. If it's not firm enough, it will have a mushy action, it won't work well. So when do you use the drop? You mainly use the drop first for bigger patients. When the ratio patient over doctor, either in height or in size, is over 1.5, then it becomes almost mandatory. So when the patient is much taller or much bigger than the doctor. Also, you use drop in case of stubborn fixation. And finally, you use drop in acute patient when you don't want too much twisting or bending. Now, there are characteristics to drop, and basically, depending on which type. Usually, the pelvic drop address mostly big body part. And the doctor trusts follow the drop up to the end of the descent and maintain that body part down. And the doctor will have 2 contacts. So big body part, maintain the drop down, and 2 contacts. The SI joint and the ligamental tension. The movement in the SI joint is very small. You know, it's an amphiarthrosis. So the ligament tension does not play much of a role in the cavitation process. It's not so much of a relaxation of the ligament. It's more of gapping the joint, because the 2 surfaces of the sacroiliac joint are irregular, so you want to gap it. That's in summary. Now, what are the main characteristics of a toggle drop? So it's for lighter structure. You have 1 single contact on the patient. The amplitude of the drop is your drop is smaller than the amplitude of the mechanical drop, because you recoil. And basically, that's allow a vibration, and it's a vibration that will unlock the tight occiput atlas segment. Thompson drop or pelvic drop, bigger structure. 2 contact on the patient, 2 contact. The amplitude of the thrust is equal, your thrust is equal in amplitude to the drop. And you maintain your contact down, so there is more a shearing force inside those joints than a vibration. So the positioning of the patient for a sacroiliac adjustment, and that's a key because very often it's not used by many of our colleagues. Sacroiliac treatment with the patient supine. Very interesting in many cases. So we're going to have the patient PSIS on the pelvic section. The lumbar section is going to be slightly raised. So we will need this that comes with the table. And we're going to place this, beautiful, at the level of the lumbar. And this nicely raise the lumbar and increase the lumbar lordosis. And we're going to use a little towel too, that's going to provide a firm mat and 1/4 of an inch up on the side of the PSIS that we want to treat. So you're going to raise that, beautiful, and we're already set up. Now, the action is simple. First, both patients' legs are straight, resting on the table, and the doctor is going to take a broad contact on the raised ASIS and use a drop to adjust. So let me set up the drop, and that the treatment will be pretty much this way. Now, we can improve that. We can improve the delivery of the treatment by using some facilitation. So the first facilitation has been the towel that we have raised that, but we're going to bend the leg on the side being adjusted. And by bringing the leg up and the patient above the abdomen, we're going to create a pelvic nudation. So the pelvic is basically going in flexion, and we're going to take a broad contact on the ASIS on this side and use it to drop. So the gluteus muscle is stretched and bring the pelvis in nudation, while the contact on the ASIS infirm that motion. And at the same time, we can also go in a light internal rotation on the hip. So let's do it. We moved it. Huh? So that's the second facilitation, the first facilitation or second facilitation, but there is another one. You can even do better than that. You can use also the bent leg, but this time you're going to take your contact, and on the opposite leg, you're going to put a pressure on the distal part of the leg to create basically a shearing motion at the level of the sacroiliac joint. So let's take a look at that. And that will be the motion. There are other types of facilitation on the anterior aspect when the patient is supine, using the patient movement and action, and I don't want to mix everything up for you, but the patient can be active also in those treatments. So what is the clinical interest of the supine position? First, it's an alternative to the posterior-anterior position where the patient is prone that we most often see used in our practice. This position enables a nudation on one side of the pelvis by flexing the leg. We cannot have that when the patient is prone, so that's one point which is interesting. Second, it enables treatment of the retrolisthesis L4, L3, L2 when the thoracic section is raised. But we could also raise the pelvic section, and in this case, it will be good for an anterolisthesis of L4, L5. And in every cases, we will need to position the anterior or the retrolisthesis at the level of the pelvic and the thoracic end section. The positioning of the patient for a sacroiliac adjustment requires that the pelvis to be raised by around ½ inch from the thoracic piece. The SI being placed just below the thoracic piece, and the lumbar lordosis created by raising the pelvis create a tension, an increase in the lumbar lordosis, and that increase in the lumbar lordosis stiffen what we call the cephalad arc of tension. So you have more tension in this area, and it creates a lumbar vertebral block. And what is the function of the block is to centralize the Newton force from the drop at the sacroiliac joint by eliminating the shock absorption of relaxed ligament like we have them normally in the lumbar. Because remember, the body is made to absorb shocks. So when you hit one part of the spine, it spreads all around, unless you create stiffness above and below the area that you treat. So for both Thompson drop and toggle drop, the arc of tension needs to be created above and below to eliminate the natural shock absorption. And you need, obviously, a ligamental relaxation at the interspace that you treat. And in the sacroiliac joint, where the ligaments are so tight, what creates that relaxation, it's a gapping of the joint. So the more the vector thrust is aligned with the facet plane, the higher the effectiveness is. And that's important. So you have to align the plane of the facet to the thrust. And because the drop is vertical, if you can align that drop with the facet plane, you maximize your result. So here, the sacroiliac is bigger on the anterior, the sacrum is bigger on the anterior side than on the posterior side. And if we had to mimic the orientation of the facet of the sacrum and the ilium, it would be like that, like the slope of a roof. So if I raise this side up, I verticalize this side. You see that? This way. And this is important to understand the mechanism. So basically, we're going to raise the side opposite to where we want to treat the patient. So the doctor trusts, if I want to treat the right side, I will be on the opposite side where I stand on the left side. And my vector thrust will push away the sacroiliac joint and press down on the sacrum, even pull it toward me. So I need to raise that side, and I'm going to do that. I'm going to take a towel, and I'm going to add the thickness of that towel on the right side. Very good. And I'm perfectly here for that. I select my drop, pelvis drop, and I will go. So I've set it up on an automatic drop, and I don't need to do that. But I could use either a single drop, or if I have the chance to have a repetitive drop, use less pressure and set it up in repetitive. So you can eliminate the use of the towel under the opposite ASIS, this one, by asking the patient to press with his knee on the opposite side of the SI being treated, making sure the pelvis on this side gets elevated. So I'm going to take that towel, and we are going to use an active participation of the patient. So I'm going to ask you, Alberto, to bend, to basically press with your knee down the table. Press down with the down, not with your ankle, down and raise. That's it. That's what I want you to do, Alberto. Relax, relax, relax completely. Now do it. Press and raise your pelvis. You press with your knee down, and that's it. Relax. I just want that side to be raised up. Press down. Beautiful. Press down. That's it. So when he does that, on this side, on the left side, I'm going to treat him on the left SI. So can you do that again, Alberto? Beautiful. And I treat him. And that way, we have verticalized the opposite side of the SI, and we're treating the right side being positioned on the left side. So the great novelty of the arc of tension approach is basically you can use an active participation from the patient. And that renders the treatment more effective, gentler and safer to the patient because you use less force. And the patient participates in his own healing, motivating him even more. We're going to treat a sacroiliac joint taking advantage of the muscle refractory period. In this case, it's going to be the quadriceps, the anterior quadriceps. So we know that when a muscle contracts, skeletal muscle contract, within 0.2 milliseconds, it cannot contract another time. So if we time a drop when that muscle that could retain that port up cannot contract, basically we facilitate the drop. But the patient needs to be greatly taught in the proper timing. And once the timing is acquired by both doctor and patient, the drop is performed. So it's very easy. I'm going to teach my patient first how to play with that. So I'm going to put my hand here under his knee and I'm going to ask him, this Alberto, I want you to press down with your knee and raise this one up, okay? So go ahead, Alberto, press up. Beautiful, relax, press up, relax. Now, I'm going to ask you, press down. Go ahead again, press down, okay? And you're going to maintain it, press down like that. But at 4, you relax. So you're going to time it up to, I count to 4. At 4, I want you to relax. So we're going to do one run to try, just to test it. Contract, 1, 2, 3, 4. Beautiful. Got it, Alberto? Let's do it. So I set up my drop, and in this case, I don't use any other facilitation. I'm going to only use this one. Take my contact here. I'm going to be on the same side of the SI, and I go, press down, Alberto. 1, 2, 3, 4. Beautiful. And that what will give you a release where many other things won't give you a release.